Hello, everybody. Welcome to our next session, the future of rejection monitoring. We're really excited to have you. We're going to get started in just a minute. But for an icebreaker, if everyone could go ahead and put in chat, what is your favorite dessert? I'll go first. Mine is tiramisu. All right, today we have two wonderful heart doctors. We have Dr. Magnetta, who is with Children's Lurie's. She did a residency at my favorite hospital, Children's Hospital of Pittsburgh. She is a pediatric heart specialist who is looking at heart failure and transplantation. And today she's here to talk to us about rejection monitoring through MRI. And then next we have Dr. Canter from St. Louis Children's Hospital, also a pediatric heart doctor in pediatric heart failure and transplantation, who's going to be talking to us about rejection through biomarkers and cell-free DNA. Welcome, Dr. Magnetta. We're so excited to have you. Thank you for presenting on this really interesting topic of other ways to look for rejection, and I'll turn it over to you.
Sounds good. Thank you very much for inviting me and for speaking about a topic I find very interesting and very important for our patients. I'm going to share my screen. Can you see the presentation? All right. So I'm going to be starting off our discussion about the future of rejection monitoring, talking a little bit more about cardiac MRI and some of the data that we have on that so far. So as we've heard recently in the last session, rejection is an important part of post-transplant monitoring, and it's something that we're always looking for throughout the life of the graft. But the incidence of rejection really is not the same throughout the post-transplant course. It's highest in the first year post-transplant, and specifically in the first few months after transplant, as shown in this graph here in the upper left. And really, what's been called the gold standard of monitoring for rejection has been cath and endomyocardial biopsy since it was first introduced in the 1970s. And here you can see in the upper right corner the technique of performing biopsy. This is done through a catheter inserted in one of the large veins, in this case, the right internal jugular vein, and through the superior vena cava into the right atrium, through the tricuspid valve, and into the right ventricle, where this tool called a biotome with a little grasper at the end is able to take small pieces of tissue, remove them from the heart, and send them to pathology for investigation under the microscope and monitoring for rejection. It's typically a very well-tolerated procedure, but has had an adverse event rate of up to 6% noted in the literature, and I've listed a few of them here. Most commonly, vascular complications. So anytime you insert catheters into large veins, you could cause bleeding. You could have clots form or injury to the vessels. You can cause a pneumothorax or air trapping around the lungs. Abnormal heart rhythms, which can be transient or in rare cases permanent. And valve injury, specifically to this valve here, the tricuspid valve, since you're going through the valve and grasping at tissue where the cords of the tricuspid valve may insert, and that can, on rare occasion, damage the valve. Here I have an example of a patient, an echo that shows the tricuspid valve here in 2D on the left, and then on the right with color through it. So red is the normal flow of the blood across the valve, and blue is leakage back through the valve. And as you can see, the valve does not really come together nicely, and there's a good amount of leakage, and this is from repeated biopsies causing damage to the valve over time. Also, especially in pediatric patients, there may be a need for anesthesia, and depending on the anatomy of the patient, there may be a need for using some radiation with the cath procedure. And then there will be a sampling error, as you can imagine. In order to use this technique and to be safe, we typically tend to sample the same part of the myocardium every time. So this RV septal area right here. And so there are patients where, after having biopsies for years and years and years, will develop scar tissue, and some of the pieces are not as diagnostic to be able to tell if there's rejection. We've had some people where they take 5 pieces and they might say inadequate, or only 1 or 2 pieces were able to be um, assessed because of scar tissue. And also, as you can see, it's not really a global assessment of the myocardium because there's all these other parts of the heart that you're not able to sample. And even when you're able to get reasonable tissue, I think that Dr. Zangwell already mentioned this, but there have been studies showing that there's a lot of subjectivity in the interpretation of these samples. And so in this one, the overall agreement between pathologists was only 70%, showing that there's still a lot of subjectivity, and this may be a limitation of biopsy. So with these limitations and with some of the risks, people have started to wonder, how frequently do we really need to be doing these biopsies? Are frequent biopsies necessary to have good outcomes in our patients? And there have been several studies looking at this. This is just one example on pediatric patients, but basically showing that on the left here, they were comparing um, how many in places that did, fewer biopsies to more, so 1, 2, 3, 4, and onward biopsies within the first year post-transplant. In how many cases were they finding more rejection, and more rejection that actually mattered, that needed treatment? And you can see, obviously, doing none, there was a difference with doing 1 and 2. But once you get above that at 3, 4, 5, and beyond, they were picking up some mild infiltrates on, or cellularity on the biopsies that they could call rejection, but it wasn't actually increasing the amount of treatment they were giving, so potentially not actually altering the course of management. And then when you actually ask yourself, well, what are the outcomes of these patients when you are comparing places that do fewer biopsies with those that do more? Long-term graft survival was no different between these two types of institutions. And coronary allograft vasculopathy, which is thought to be a complication that can occur with repeated episodes of potentially undiagnosed rejection, was no different between the two types of institutions. This paper wasn't able to really assess like what other modalities these places were using that used few biopsies, but it just shows that potentially more biopsies may not actually be better for routine surveillance. So then, as we're thinking about what are alternatives to biopsy for screening for rejection, since we do need to monitor for this, there are different things you can look at. Obviously, you can look for clinical signs and symptoms, as was mentioned in the last session, but often we don't want to wait until rejection becomes so significant that it causes dysfunction of the graft and symptoms, but it's definitely something we're always screening for. There have been several studies looking at different labs you can check, and often we trend things like a BNP number, troponin, and then there are novel biomarkers that you'll hear about. Some of those have had variable results in terms of how well they correlate with rejection, but we still use them as a trend. And then there's imaging studies, which I'll talk about. Obviously, echo, which all of our patients get on a routine basis, and then MRI. And so when I think about what's a good screening test for rejection, or a screening test in general, I like to think of a test that's low risk, that's highly sensitive, meaning you're not going to miss patients who have rejection. It's relatively accessible and affordable, and it's reliable, meaning if you get a study on one patient, and if you show it to multiple people, they'll come to the same conclusion, or you can reproduce this among different patients. So it's something that people agree upon normative values and things like that. So just thinking about two of the imaging modalities that will come up a lot in cardiac transplant, echo and MRI. I put together just a little bit of compare and contrast between them because, as echo will continue to be one of the parts of the evaluation for our patients. And it's typically, more affordable than MRI. It's readily accessible, whereas MRI might be a little bit more institutionally dependent. But echo does have variable image quality. There'll be plenty of patients, especially in the older years, that may have poor, what we call acoustic windows, or you can't see the heart very well. And so that may limit your ability to do some of the measurements that have been correlated with rejection. MRI, on the other hand, usually has pretty good image quality, um, and so can be a little bit more consistent. Echo does not do a great job at characterizing the tissue composition, whereas MRI does that really nicely, and I'll show you some examples. Echo can pretty much be done on any patient anywhere without anesthesia, radiation, contrast. MRI may be limited in some patients if they have an implant that's MRI uncompatible, but that's becoming, fewer and far between. There may need to be anesthesia, especially on younger patients, so that adds a little bit of risk to the procedure. And then there's no radiation with MRI, and you may or may not need contrast depending on the study. And then finally, echo is something that, has been pretty well established between institutions, has pretty standardized ways of performing measurements, and we often use these normalized values between institutions, so we always are able to compare things. MRI is a little bit more variable between institutions, different protocols, and the normative values are still being established in some populations, so that's something that also may be a limitation. So in thinking about how these play out with monitoring for rejection, there have been several studies for echo, and this is very small, but just sort of to point out that there have been a lot of studies over the years looking at which echo parameters could maybe help you assess for rejection. And some have shown some promise, and a lot of it may depend on image quality and what you're able to get from patient to patient. But mostly the correlation with rejection has been really no better than fair correlation. And so I think it leaves a lot to be desired as a primary screening modality. So then the question is, how does MRI perform? So I am by no means a radiologist, but I think it's good to cover some of the very, very, very basic MRI physics to understand how the MRI image is acquired so that we can compare some of the results that we get and how people are using that to look for rejection. So basically, the way that it works in a very basic level is that we all have protons that are spinning throughout our body in various orientations. And when a person is placed in an MRI magnet, all of those protons are aligned either in the orientation or against the orientation of the magnet. And then what happens is a radio frequency pulse is passed through the person and knocks the protons to the side, and then they are slowly flipping back to realign with the magnet at their own time, basically in their own speed. And as they do that, the protons release energy, and that's harnessed to create an image, which we can see as an MRI. And so the time that it takes for each of these protons to return to that baseline configuration where they're aligned to the magnet tells you about the tissue composition that you're looking at, which is really interesting. And so that can be measured here, as you can see, as a signal intensity over time or a relaxation time. And those are the things that we're looking at with an MRI to see if they change with rejection. So that's some of the values I'll talk about now. So depending on the way that radio frequency pulse is generated and passed through, you'll either get a T1 or a T2 relaxation time. So it's not important to understand exactly what made those T1 or T2, but just know that those are two of the measurements that we look for. And they're both increased basically in situations with a lot of water content in the heart muscle. So you'll see elevated T1 and T2 relaxation times when there's myocardial swelling or edema, inflammation, and then T1 is elevated as well in fibrosis. And then there's a value called extracellular volume, or ECV, and that's actually a calculated value from pre and post contrast images using the T1. And that's used to estimate the size of the extracellular space. So another way of looking at basically water content, and can be elevated in the same things that you would see for T1 relaxation time, but that does involve some contrast administration. So here on the right, you can see an example. So the top four panels versus the bottom four panels. The top four panels, it's a patient with active rejection. And the bottom four is someone who does not have any rejection. And just visually, so the circle is the left ventricle on a short axis view. And just visually, you can see that the color is different and it's small, but what that actually means is that the ECV values are higher in this patient. So these are in the 40s and the high 30s versus in this patient without rejection, that's purple, they're more in the 20s to 30s. So you can just see that in this patient with rejection, the ECV values are higher, and that can be a really useful tool for looking for rejection in a global way. And then another thing that we look for is called late gadolinium enhancement. And basically, this is something that you do need to administer this gadolinium contrast, and the myocardium takes it up and it leaves kind of a mark on the myocardium where there's fibrosis and scar, and it looks white. So here you can see this is in the middle of the myocardium where the arrows are, that it's taken up white, and that means that there is gadolinium enhancement. This is not quite as sensitive for rejection. It can be elevated in other cases, so ischemic time or how long it took to get the heart from the donor to the recipient during the operation. If you had an older donor, if there's coronary allograft vasculopathy, if there were lots of prior biopsies creating scar, you can get late gadolinium enhancement just from those things. There have been studies that show that elevated late gadolinium enhancement, or lots of it, could be predictive of long-term outcomes, where these more late gadolinium enhancement predicted major adverse cardiovascular events. So it could be an important tool, but maybe not as specific for rejection. And like I said, this does require contrast administration. So then looking at how these measures actually correlate with rejection, a lot of the data has, of course, been done in adult studies as they have more patients and as they've been using this modality longer and more frequently to look for this. But basically, these are just two representative studies in the adult literature, one looking at the T1 values and this one looking at T2. And you can see, so group 0 is the group with no rejection. Group 1, very mild rejection, or what Dr. Zangwell mentioned, may not even be considered significant rejection in some patients. And group 2 is moderate to severe rejection, or clinical signs of rejection, which we usually call severe rejection. And you can see that the T1 values are higher in those significant rejection, and it's statistically different. Same thing here, where you see that more severe rejection, antibody-mediated rejection, and clinical rejection showed higher T1 values. And then in panel D here, patients who had rejection and then were treated showed decreases in their T1 values with treatment, which shows another nice form of correlation. And then here, T2 relaxation time similarly was elevated in all of the moderate to severe rejection, AMR, and clinical rejection. Pediatric data is pretty limited still, but there's a lot of interest in some ongoing studies on this. For example, this earlier study from 2020, very limited in numbers, just showed a trend toward increased T2 in moderate rejection, but numbers too small to really analyze further. And then here, this larger study with 12 patients who had rejection versus 21 who did not, showed basically what the adult studies have shown, which is that global ECV and T2 scores were higher statistically in the rejection group than in the non-rejection group. The global T1 scores did not meet statistical significance, but did look higher, so potentially just limited by patient numbers. And then LGE really was no different between the groups. And then this was a meta-analysis by the adult centers that basically took a lot of these big studies and put them together to say, if you pool all that data, how does MRI perform in all of these parameters? And it pretty much confirms what has already been shown, but just a little bit more detail, that if you look at the sensitivity of T1, T2, ECV, and late gadolinium enhancement, really those first three have pretty good sensitivity for rejection, late gadolinium not so much. And then if you look at the specificity, how specific is it for rejection, T2 still holds up pretty well versus the other ones falling down, probably because other things can cause myocardial fibrosis, not just rejection. And so the overall performance of these parameters is best for T2, but also still pretty good for T1 and ECV. So then finally, just taking a little bit of a closer look, I thought this was a really interesting study because it shows you that it's not really so straightforward as just a number. I think it's something we still need to learn a little bit more about. So this they chose here to compare not only patients with and without rejection, but transplant patients to non-transplant patients and those who had prior rejection. And so on the left panel is T2, on the right is ECV, but basically the controls are patients who've never had a heart transplant. The transplants, no rejection, so patients who've had a transplant but don't have any history of rejection. And then patients who had prior rejection but are not currently rejecting, and those who are currently actively in rejection. And you can see obviously visually that the actively rejecting patients have very different values just by the colors. And then if you look closer, the numbers are all more elevated in those, and it's all statistically significant. But you notice that even if you compare patients who had a transplant with no rejection to healthy controls, their values differ. And potentially patients who've had prior rejections, theirs might differ a little bit as well. And also, if you look at the different regions of the heart, the colors are slightly different, and there's a little bit difference in which regions may be affected by certain rejection over time. So I think this was really interesting in that it brings up more questions that need to be answered. So first of all, what are normal tissue mapping parameters for heart transplant patients? And how do they change over time? Are they the same when you're, 6 months post-transplant or to 12 years post-transplant? I would imagine some things will change over time. Are certain regions more important than others when you're assessing for rejection? And how does the sensitivity of MRI change when you've had prior rejection or when you have graft dysfunction? So those are things I think that still need to be figured out. And again, this is adult data, so we also need that figured out in pediatric data, as that may change as well. As children often are very young when they get their heart transplants and they grow quite a bit. How do their MRI mapping parameters change over time? So kind of just taking a step back and looking at everything, I think it's important to know, biopsy still does remain what we call the gold standard for diagnosing rejection, but it's possible that we may be able to move away from doing routine surveillance biopsies, so meaning a patient who's doing well, who doesn't have any concerns for rejection on non-invasive testing, getting frequent or routine biopsies, and really instead using these non-invasive tools to narrow down to the patients who actually need biopsies. Because as you know, if you were to have some abnormalities on non-invasive tests, you still need to know exactly what's going on in order to tailor your treatment. So I think there's an important role for biopsy, but maybe it doesn't need to be used as a first pass surveillance. And we also do need more data. We need more longitudinal data. We need normative values to be established, and we need to know what is normal and expected for pediatrics, so we can use that for our patients moving forward. So that meta-analysis I mentioned, I think, said it in a really nice way, as they said, perhaps we can use these tools as a gatekeeper to biopsy. So I think, biopsy still hanging in there as the gold standard, but perhaps we can use tools like imaging as a first pass screening test to see if we really are worried about rejection, and biomarkers, which you'll hear about soon, to see, as gatekeepers to biopsy so that we can reduce the risk to our patients without compromising any outcomes. So that's all I had to talk about today. I want to say thanks again for inviting me, and I look forward to discussions.
Well, thank you, Dr. Magnetta. That was really fascinating. I really appreciate that. As a liver mom, I learned a lot about heart today. So everybody, if you have questions, please put them in the chat. We are going to answer those at the end. Next, I'm really excited to introduce Dr. Canter. Dr. Canter is a pediatric cardiologist at St. Louis Children's. He also is affiliated with Phelps County Regional and Barnes Jewish Hospital, and he is here to talk about biomarkers and cell-free DNA. So Dr. Canter, welcome. I am going to turn it over to you.
Thank you. Well, I appreciate the opportunity to talk at the conference. I'm talking from my hotel room because right now, going on right now is the annual Heart and Lung Transplant conference for all thoracic transplants here in Boston. There's lots of stuff on this non-invasive and alternative ways of diagnosed rejection, especially in the pediatric age group. Again, because I'm a cardiologist, most of what I'm going to talk about is going to be related to data from hearts, but I will tell you that much of the same things have been also seen in other organs, especially kidneys and lungs, because they do get rejection. Livers, not so much, because liver transplants probably the best of all solid organ transplants, don't have as much rejection. So starting ahead with, as I said, we really have, I'm from Washington University and St. Louis Children's Hospital. My disclosures are that I'm on a medical advisory group for myocardia and CareDx. So when we talk about rejection really in any organ, there are actually two types of rejection. One that's called cellular rejection, and this is what the heart biopsies look like with cellular rejection. That rejection is caused by cells, T cell lymphocytes, that attack the graft directly. And when you look at the cells, you'll actually see with rejecting hearts, little clusters of these T cells in the middle of the heart muscle, damaging or killing heart muscle cells. This has been known most about, and for a long time was felt to be the only type of rejection that one saw. But for the last 20 years, it's become increasingly evidence there's another type of rejection that's mediated by antibodies, or often what is called B cell rejection, because B lymphocytes manufacture antibodies and lead to rejection. And you can see here, when you compare the two slides, that on a microscopic level, they're very different in that antibody rejection often attacks the small blood vessels or capillaries within the organ. So all the inflammation and attack is right here in the vessels. And then you'll see deposition of products of this inflammation, what's called complement split products, or C4D. Oftentimes you'll see antibodies in the serum that are specific to the donor's HLA type, or donor-specific antibodies. This type of rejection for a long time really didn't have specific pathologic standards. And one of the things that is common with antibody-mediated rejection, it's often associated in hearts with overt decreased function of the graft or ventricular dysfunction. So when you're looking at things to non-invasively diagnose rejection, you're really trying to see some that you're going to diagnose both cellular and antibody-mediated rejection. Now, currently, what do you use clinically in the hearts and in other organs to diagnose rejection? Well, it's really a matter of 6 things. As Dr. Magnetta said, biopsy has been the gold standard for 40 years with a solid organ transplantation. It was considered at the time it was developed in the early 80s, one of the things that initially made transplants a reasonable clinical option. But there's other things. You use, obviously, as she just discussed, changes in heart structure and function. You often will use clinical symptoms. And in pediatric heart transplantation, especially infant transplantation, for a long time, clinical symptomatology was used to be an important way to raise suspicion for rejection. You will try to look for evidence of activation of the immune system and increased inflammation. You will look for injury to the cells of the organs and hearts. It would be myocytes. And then very often you'll use epidemiologic factors developed over time to try to identify patients and situations where there's a high risk for developing rejection. So currently, when we're trying to decide is somebody in rejection or not, we probably use all of these to make that decision. And oftentimes, once we see all these 5, we then go to a biopsy to say, well, is our thoughts right or are they not right? So how do these tools actually function right now? Where do you act? Because there's many, many tools that are used for assessment of rejection. Biopsies actually are not, in many ways, not a total gold standard, and often they're somewhat tarnished goals. They have a false negative rate for rejection. They are dependent upon how many samples you take. It's also dependent on where you take it. Very often, a biopsy the tool used to do the biopsy goes to the same place over and over again. You'll develop scar tissue. Sorry, oops.
Sorry, Dr. Canter, your slides weren't loading. What slide do you want to be on?
3.
There you go. I'll have to move them for you, but I'll
Okay,
go ahead
next
and do
slide.
that.
Next slide. Okay, so here's the assessment tools, and biopsies can be false negative, and they're subject to interpreter error. Pathologists will grade them differently from one pathologist to another. So they're imperfect. They're pretty good at showing if you can see rejection on a biopsy, that's pretty good that you have rejection. But the absence of seeing rejection on a biopsy does not necessarily mean that there is no rejection. Imaging or echocardiogram has been used for the longest time. It's good at measuring heart function and heart size. It's pretty good for showing things that are an absence of rejection, but really not so good for the presence of rejection, because a lot of things can make a heart work better or for worse. MRI kind of gives you the same thing, but also it can also give you a sense of myocardial injury by assessing edema and scar tissue. And there are even some studies that it can suggest activation of the immune system. But it's just been recently applied to rejection assessments, so I think the results are still somewhat out. Now, there are a number of blood tests that we're currently using to assess how transplanted hearts are doing. One of them, what are called natriuretic peptides, are measurements of small pieces of protein that hearts produce when they're failing or having elevated pressures inside the heart. So they're really a good sense of heart function. People use them as another way to screen for rejection, but how good or bad they are for that specific diagnosis is really uncertain. In a similar fashion, serum troponins. Troponin is a protein, an enzyme that is seen in heart tissue. It goes up with heart injury. It's most commonly used in the assessment of adults for myocardial infarctions or coronary artery disease, but it can be used for any sort of graft injury or myocardial injury. It, again, has not been studied exclusively for rejection assessment. Sometimes it will be elevated, sometimes it's not. Hard to know exactly where it fits. DSA, or donor-specific antibodies, are used as a marker of immune activation. And at this point, they're more a risk factor for developing an antibody-mediated rejection as opposed to a way to specifically diagnose rejection. Then finally, we have various blood tests that have been developed really over the last 15 years or so. The first one, what's called an immunoassay, actually measures activation of lymphocytes. So it's more a marker of immune activation. It's been around for over 15 years. And actually, what's interesting about that, it's very good at showing if the immune system is not very activated or is in many ways over immunosuppressed. So it's very good for the absence of rejection, but it's not very good for measuring actually overactivation or specific activation of the immune system. It didn't turn out to be very good for diagnosing the presence of rejection. Now, the two clinically available most recent tests are all done by the same company, CareDx. The one that's been around the most is what's called an AlloMap assay, and it measures actually activation of specific messengers or messenger RNA from the DNA in cells to make proteins to activate the immune system. And this test has been used clinically now in hearts and other transplanted organs for about 15 years. It is very good, extremely good at showing a situation where there is no rejection. It's so-so and really not real good for determining if there is rejection. And many of these current blood biomarkers, that's what they do. They tell you with high confidence if you don't have rejection, but they're not real good at saying, yes, you do have rejection. But in a clinical situation, knowing that there's a very limited or no chance for rejection, that's very valuable for clinicians. The final one that's just recently, within the last 5 years, shown up in regular clinical assays is what's called cell-free donor DNA, and that's labeled as an AlloSure pathway. It measures the presence of donor DNA, or the DNA that's from the donor that comes from injury of the organ that's donated, and is measured as a percentage of total DNA in the bloodstream free of cells. And again, those studies show that it's actually very, very good. You'll see in a second, for showing when there's no rejection. And again, not so good in saying that there is rejection. So that's where we are overall right now clinically. We're going to go into a little more detail here in terms of these last two studies. The first one we'll talk about the AlloMap assay. And what that is you're measuring the expression of genes or DNA in measuring their messengers to make protein or RNA. So they measure gene expression profiling in mononuclear cells or lymphocytes. They actually the executors of the immune process. And there were two main randomized trials in adults that were done, as you can see now, 15 years ago. And what they found was that they could diagnose the absence of cellular rejection with a negative predictive value of 99% in the cargo study. And then that was followed up 5 years later, where they applied it to see what that would mean for being able to reduce overall biopsy load. And that was in the imaging study. And actually from that study, there was a substantial, significant reduction in the use of surveillance endomyocardial biopsies without any effect on transplant outcomes in adults. So as a result, for a long time, adult transplant recipients at most centers are screened with AlloMap routinely to try to confirm that there's a low risk of rejection or a high probability that they have no rejection. AlloMap, however, one limitation it was designed to assess cellular rejection. So it really has no value in the diagnosis of antibody-mediated rejection. Next slide. So why isn't it used in children? Well, the reason why it wasn't used in children is actually there was a study done back in 2006. That was the pediatric component of the cargo study. And these are slides back from the American Heart Association presentation at that time of using the AlloMap study in children. And the study was done at Columbia and Stanford and Pittsburgh, all prominent pediatric heart transplant places at this time. And the problem was that the results in children were very different than what they were in adults. Adolescents match pretty well to adult values, but younger than adolescents and young children tended to have higher scores than what was found in an adult. So overall, the threshold criteria for showing the absence of rejection changed apparently for children compared to adults, which meant that the criteria that were being used to exclude rejection from AlloMap were not all that relevant to children, because the RNA expression or the expression of the genes was different in children than adults. This study showed what's a long-standing saying you have in any pediatric situation is that children are not young adults. This proved that when the gene expression profiling, that was true. They were not young adults. And interestingly, you'll see this differences in RNA expression in a lot of clinical situations between children and adults and others in other heart diseases such as cardiomyopathy and heart failure. So it's not just for this situation, but for a lot of situations. But for this reason, these studies were never published because it was a negative study and children have small numbers. But for this reason, it's one of the main reasons that AlloMaps are not routinely used in the pediatric heart transplant population, or really the kidney or liver population, as they are in the adult world. So next slide, there have been a few other situations where it's actually been looked at pediatrics, and this is some recent experience from Dr. Das, and just confirms what you saw from the study in 2005. And if you look at the people who are rejecting grade 0 versus other rejections, the dots really don't change, no difference. But again, this actually is a fairly small amount of data, so it doesn't have a lot of confidence because the numbers are so small, which unfortunately is the problem we have in studying pediatric heart and other pediatric solid organ recipients, and especially of these techniques. As most of the time, when you measure these things, there is no rejection. And actually, these days, as the overall prevalence of rejection has decreased in pediatric hearts in a similar fashion as had kidneys, livers, and to some extent lungs, when you try to assess these instruments, you're desperately trying to find rejection eps to see the difference. But very often, there aren't, in a short span of a study, you just can't find that many episodes of rejection, which means it limits what you can do with the study. But as you can see right now, at this point, use of AlloMap by itself in a pediatric population has its challenges, and it therefore is generally not done. Next slide. So the next test is cell-free DNA, and CareDx markets both the AlloMap and now the AlloSure. And again, this uses donor-derived DNA that you find in the plasma. What happens when cells are injured, when the cell is destroyed, the DNA from that cell gets into the bloodstream. And you can measure through various techniques how much DNA in the bloodstream is from a donor organ versus what are from organs from the patient's own body that were not transplanted. Then you could, the marker that's assessed is the percent of donor DNA versus the host or the recipient's DNA. And again, so when things are going well in quiescence, as you can see over the right, there's very little donor specific cell-free DNA in the bloodstream. But when there's injury, and oftentimes the injury, once you get past the first weeks of life, is from rejection, then the proportion of cell-free DNA increases. And again, AlloSure has been studied in hearts, kidneys, and lungs, and the results are fairly consistent across all organ systems, showing that that as rejection occurs, the percentage of donor DNA goes up as a proportion of the total cell-free DNA in the bloodstream. And what you'll see here in a second, comes from studies that show it has excellent negative predictive value. Next slide. So this first study was done, as you see, just about 3 years ago, and this is an adult study of AlloSure measurements. And you can see that AlloSure at a specific thresholds of how much cell-free donor DNA is there versus recipient cell-free DNA, that it has a really tremendous negative predictive value of nearly 99%. So if you're below a threshold, you have a 99% chance you don't have rejection. And different from AlloMap, cell-free DNA values held true for acute cellular rejection as well as antibody-mediated rejection. So this was somewhat a one-size-fits-all, or used in every situation to exclude the presence or reassure you that you don't have either cellular or antibody-mediated rejection. And now this test is clinically available, and our adult colleagues have added to their armamentarium of non-invasive blood biomarkers for rejection surveillance. So there have been a few pediatric studies using cell-free DNA in terms of an assessment for rejection and its comparison with biopsies. Next slide. This is a study. This is an old, oh my. Go past, we're going to go back and forth because I've got you keep. Okay, this study shows the first one that came out in 2020 from a group of pediatricians that included Dr. Zangwill, by the way, and there's different assays for cell-free DNA. The one that was used in this study that was developed by Dr. Zangwill and others at the University of Wisconsin ultimately did not become clinically available. But despite the way it's assayed, it all shows the same. And again, they found in a smaller number of patients, this study is pediatric patients and adult, they confirmed a high negative predictive value for both cellular and antibody-mediated rejection that exceeded 90%. Next slide. So this year, and this was just published a couple of months ago in Pediatric Transplantation, Brian Feingold of the University of Pittsburgh applied AlloSure findings to begin to avoid surveillance biopsies. And you can see as highlighted in the yellow here, he was able to reduce the use of surveillance endomyocardial biopsies in a pediatric population for 83%. And this is clearly a pilot study with a limited number of patients in one center, so it's not definitive. But this shows, as other studies have come out, that the same pattern of cell-free DNA with and without rejection seems to occur in children regardless of age, making this tool very attractive for applicability to the pediatric heart transplant population and for other pediatric solid organ recipients. So in this case, we're excited about, and there's much available interest in trying to figure out how we're going to expand this and bring this to routine clinical use in the near future. Next slide. So aside from these markers, these are what are clinically assessed. There's other markers that are in the pipeline. And from this slide, it's not just proteins like troponin and natriuretic peptides. It's not just cell-free DNA. It's not just messenger RNA and expression. There will be other things. It appears that adding some methylation or some chemicals to DNA may be a marker of rejection. It looks like small fragments of RNA, what are called microRNAs in the circuitry, may also be a marker. And there are certain vesicles and metabolic pathway markers that also may be potential markers. Next slide. And if you look at what's their sensitivity and specificity and predictive value is, you can compare these to the clinically available ones. GEP is AlloMap, DD, cfDNA is AlloSure. And again, you can see overall from this study that was recently published that overall AlloMap and AlloSure have a very poor positive predictive value for rejection, but really a fantastic predictive value of over 95% to show you don't have rejection. But you go to these investigational markers, and all these markers are from studies that are pilot studies, no large clinical explanations, so they haven't been confirmed in larger studies. So they're very preliminary. But some of them, like the S1P and the SRC2A, have promised to be able not just to tell you if you have no rejection, but actually may be able to tell you if you have rejection. What these studies need is more clinical validation in large populations, and that is underway. So it's possible even in the next few years that some of these studies may actually supplant AlloMaps and AlloSure because there'll be better studies that can tell you not only if you don't have rejection, but also that you do have rejection. But that is to come and it's not there yet. Next slide. So I want to go kind of the next slide. Okay, I want to go back to previous ones. Okay, this slide. The other thing, though, about cell-free DNA that's important is that it does not specifically measure graft injury just from rejection. Any graft injury will cause an increase in cell-free DNA. And so since a transplant process will injure hearts, cell-free DNA levels immediately after transplant are very, very high. As shown in these graphs here from a paper published in Circulation. Again, this is using a different mechanisms assessing cell-free DNA than AlloSure's, but it's the same principle, and AlloSure's have found the same thing. And you can see shortly after a transplant, cell-free DNA proportions are very high, and they generally go down to a baseline that are fairly consistent after about 6 weeks after transplant. So for that reason, AlloSure and cell-free DNA assays generally aren't implicated until at least about the first few weeks after transplant. All right, can we move forward back to where we were? Okay, so back one more. Okay, back another one. Sorry about that. So that's where we stand right now. And so I think what you could say right now, I think there is great promise for pediatrics to begin to use cell-free DNA assays or AlloSure as a way to begin surveillance in a pediatric transplant population. We've started using it in the last 6 months at St. Louis Children's Hospital, and we're seeing kind of in a small number of patients the same situation. And I expect as we get more experience with it, we'll be using it more, as I do believe other centers will. But there's also other things about cell-free assays that are very intriguing that have just come out recently. And it goes to, when do you want to catch the rejection? So rejection often, if it's not treated, not caught early enough, can lead to symptoms of graft dysfunction or even graft failure. Rejection is a cause of ultimate failure of grafts. And in the heart world, retransplantation is not a good option for graft failure from rejection because the immune system is already activated and will reject the next graft, and outcomes are poor. It's also true in hearts that if you have rejection so with overt heart failure, hemodynamic blood parameter exercise or lower blood pressures or hemodynamic compromise, you may be able to get a patient through that episode, but the long-term prognosis is poor with something like a 50% mortality within 6 to 9 months after the episode of rejection with hemodynamic compromise. So for hearts and kidneys, of course, that would translate to losing a graft and having to go back on dialysis, which can happen from rejection in kidneys. So what you want to do when you're trying to figure out rejection is catch it not when you have acute clinical symptoms, not when you begin to have evidence of dysfunction of the graft, and certainly not when the graft's failing. You want to catch it here at the preclinical stage where you have evidence of graft injury, but normal graft function and no symptoms. This is the ideal place to catch rejection. And indeed, there is long-term epidemiologic evidence in pediatric heart recipients that rejection that's caught and treated at this point doesn't lead to graft injury or long-term graft dysfunction. So you have every reason to try to be able to catch rejection at this stage and not at these stages down here. Next slide. And it's this recent data regarding AlloSure that's making everyone excited. Because what happens in AlloSure, especially in antibody-mediated rejection, which is this panel, an antibody-mediated rejection is often associated with dysfunction of the heart and can lead to graft failure, is the AlloSure levels start going up substantially before the biopsy turns positive. Now, it also happens in cellular rejections, you can see up here, but you see that the time course is much longer. So there is potential with routine surveillance with AlloSures that you can begin to detect rises due to antibody-mediated rejection before the biopsy becomes positive and before you have graft dysfunction and before you have graft failure. So people are beginning to hypothesize that surveillance with AlloSure, and you start seeing rises in a time when it's very unlikely that there's graft injury from other reasons, that actually you may be able to intervene on the basis of an AlloSure level with enhanced immunosuppression and stop overall acute pathologically defined rejection before it happens, which means you could reduce the rate of rejection with hemodynamic compromise and improve long-term graft survival and also long-term survival recipients. That part of it is perhaps the most exciting part and what needs validation both in the adult and pediatric world. But I fully suspect that those studies are beginning to be designed in adults. I know we're thinking about them in children, and they're likely going to occur in the next few years. So next slide. So in summary, where do we stand as far as this situation? Well, over the years, we've had 3 ways to try to diagnose or put the dart on target with rejection. It started with biopsies. And then in the hearts, we have all sorts of cardiac biomarkers, which includes blood tests and echoes and MRIs and measures of function. And now most recently, we have all sorts of blood-based biomarkers that include measurements of DNA and AlloSure, RNA and AlloMap, various proteins, and maybe in the future, metabolites or little pieces of cells or exosomes. What's going to happen? More than likely or not, All these will continue to be used to help in the diagnosis and management of rejection. It'll likely be that some will be used a lot less, such as biopsy, as they are now, but then none of them are ever going to go away. And so it's going to be a matter of not just moving forward, finding out which ones we can do to minimize surveillance biopsies, but what combination of these tests will give us the most knowledge and provide us the best way of keeping every recipient's heart the healthiest. So with that, I'll stop, and I thank you for your attention and appreciate the opportunity to give this talk today to your audience.
Well, thank you, Dr. Canter, and thank you, Dr. Magnetta. This has been really educational, and it's a lot of good information. Really quickly, we got a couple minutes. I want to do two things. One, we have an Amazon card giveaway. So for those of you, go ahead and put it in chat. We're going to pick from which one who gets this right. But in minutes, how often is someone added to the transplant list? And you can go ahead and put that in there and we'll find a winner. But Dr. Magnetta, this was for you regarding the MRI. The question was, do you think that a baseline MRI is something that is needed in order to kind of screen for rejection? And your thoughts on that?
Yeah, I think that's a really good question since, we still don't quite have standardized values, especially in pediatrics for baseline heart transplant MRI mapping values, but also in various stages of rejection. So something we've started to try to institute at Lurie is getting baseline MRIs if possible, trying to balance things like does the patient need sedation and whether it can be scheduled in a timely manner. But I think getting a baseline on a patient could be valuable as we don't quite know what normative values are. And then later, if there are concerns, we have something to compare to. So I think that's a really good point.
Thank you. And I wish we had more. I know there's a lot of great questions, but we are running right to the hour. So I am just going to say thank you, everybody, for your time. Our next and last session today is the power of one, redefining advocacy and policy to help transplant children. So if you are interested, you can go ahead and leave this session and head over to that. Thank you again, Dr. Canter, for taking your time during a conference, and Dr. Magnetta. It's been a pleasure to listen to both of you, and have a wonderful afternoon, everybody.
Thank you so much.